Good evening.
Hi.
Adrian.
हेलो सर, ये आपने अमेगा सिंह 500 mg डीडी बोला था ना? 40.
Varsha? Hello, Varsha?
Yes, ma'am.
Yeah, you will share the CVs, na? When
Yes,
like so I'll,
yes.
He knows this thing, no? Yes.
Yeah, sequence, na?
Sequence, yeah.
Yes. Yeah.
Hello, Tareen sir. There is Jessie madam.
Olina ma'am, I am on mobile, so I'll not be able to see who all are there. So in case Divekar ma'am and all comes,
Yeah,
you
yeah,
just
that I
tell
do.
them.
Yeah, it's fine.
Okay.
Yeah, sure.
Still, we are only 7 of us.
Yeah. Our speakers also not. It's 30 already. Pallavi, where are your friends?
Ma'am, I told everybody to join, but they haven't really joined.
Hello,
Yes,
ma'am. Jessie
Yes.
ma'am.
Hi.
Yeah, hi.
Hi.
Jessie.
Yes, good evening.
Good evening.
Pallavi, Jessie. Then Tareen sir again.
It's okay. Now I just attended 5 o'clock ISA online, no classes are there. Such beautiful topics, but hardly 50, 60 means all over India and 50, 60 people only join. It's so sad.
No, but later I see the YouTube now, then the number goes up, but live very few people see.
YouTube is okay. Later people see.
But the speakers feel,
Yeah, it is.
there's no interaction, no
But it's
questions.
okay. But on the same hand, in Nanded also I see now Nanded people have every week since they started. And they have sometimes 6, 4, but they hold it. And that is great. I feel that's the spirit.
Sweetie has joined.
Yeah.
Then and after that, he repaired the CSF area hydrogen effect.
Hi, sweetie. Good evening.
Good evening.
Then the CSF stopped. After that, he put her.
Jessie, even Dr. Kala has not joined.
Yeah, better keep your mobile here. एक मुझे टाइम देखना रहेगा तो
Has Nilesh slept off like last time? Should we send him a reminder call?
Reminder, na? He's the last speaker, so it's okay. Dr. Kalla is also not joining. Dipsy, I should call Dr. Kalla.
No, it's okay. No problem. They'll join.
Because Pallavi is in hardly 10 minutes.
No problem.
Dr. Nilesh joined.
Good. Nilesh, good. Thank you.
Hello. Hello. Reena, can you hear me?
So Abhi, he told me to add amicus in 500 mg.
Okay, Kala has also joined. I think we can start now.
Hello.
Yes, sir.
Yeah, can you hear?
Yes, sir.
Yeah, we can hear you. Good evening, Dr. Nilesh.
I.
Hi.
I'm not
I
sure
think now we can start. Everyone's
here
here.
or
We start, Najisri.
Yeah, please start. Plece start. I have a network issue, so I'm putting my video off. But I am there very much, not sleeping.
So, good evening, everyone. Welcome you all to the fourth webinar.
That bus was taken out fully.
Others, please mute your. Good evening, everyone. Welcome you all to the fourth webinar of ISC Navi Mumbai. Welcome all the speakers, Dr. Nilesh Kadu, Dr. Pallavi, Dr. Sweetie Purushottam, and Dr. Kala Ishwaran. I don't know this. Dr. Kala Ishwaran, welcome. Welcome all ISA Navi Mumbai members and other participants. Now I request our Joint Secretary, Dr. Reena Gautam, to introduce the speakers and conduct the academic program on regional anesthesia further. Over to you, Dr. Reena.
Yeah, good evening, all respected seniors and colleagues. Today's topic is supraclavicular blocks. So just for information, this supraclavicular block was first performed by Dietrich Kuhlenkampf in Germany in 1911. So to go about with this, our first speaker will start with anatomy of brachial plexus. She is our enthusiastic budding anesthesiologist, Dr. Pallavi Goel. She is senior registrar at DY Patil Hospital. And Dr. Pallavi, welcome you and for
Thank you,
this
ma'am.
talk. Yeah, thank you.
Good evening, everyone. I will be talking about the anatomy of the brachial plexus. So the nerve supply of the upper limb is via the nerves emerging from the brachial plexus of C5, C6, C7, C8, and T1, along with the intercostal brachial nerve, which is T2. The parts of the brachial plexus can be divided into the following parts, as can be seen in the figure: the roots, the trunks, the division, the cords, and the terminal branches. The roots of the brachial plexus are formed by the ventral rami coming from the spinal nerve C5 to T1, as can be seen in the figure. So for the brachial plexus, there's something called as a prefix and a postfix. A prefix is which C4 spinal nerve acts as a prefix, and postfix the T2 spinal nerve. The trunks of the brachial plexus are three: the superior trunk, the middle trunk, and the inferior trunk. The superior trunk is a continuation of C5 and C6 root. The middle trunk is a continuation of C7 root, and the inferior trunk is a continuation of C8 and T1 roots. The divisions: each trunk will further divide into an anterior and posterior division and then form cords. The cords are formed by the 6 divisions that are formed by the trunks, and they are named according to the relation with the axillary artery. So we have 3 cords, namely the lateral cord, the posterior cord, and the medial cord. The lateral cord is formed by the anterior division of the superior trunk, the anterior division of the middle trunk. The posterior cord is formed by the posterior division of all the 3 trunks, which are the superior, middle, and inferior trunk. The medial cord is formed by the anterior division of the inferior trunk. So it's an easy mnemonic to remember the divisions of the brachial plexus. Read that damn cadaver book, which is roots, trunks, divisions, cords, and branches. So the branches of the brachial plexus. The lateral cord gives 3 branches, which are the lateral pectoral nerve, the lateral root of the median nerve, and the musculocutaneous nerve. The middle cord gives out 5 branches, which are medial cutaneous nerve of arm, medial cutaneous nerve of forearm, the medial pectoral nerve, the medial root of the median nerve, and the ulnar nerve. The posterior cord gives again 5 terminal branches, which are upper suprascapular nerve, lower subscapular nerve, the thoracodorsal, the radial, and the axillary nerve. So we'll from here go on to individual terminal branches. So one of the main branches is a musculocutaneous nerve. The roots of the branches are C5, C6, and C7. In the figure, as you can see, the blue portion is the musculocutaneous nerve, which has a motor supply to brachialis, biceps, and coracobrachialis. In the smaller figure, we can see the sensory supply of the musculocutaneous nerve, which is innervated by the lateral half of the, which innervates the lateral half of the anterior forearm and the small lateral portion of the posterior forearm, as in the picture with orange markings. Axillary nerve. The roots of the axillary nerve are C5, C6. It innervates the yellow markings up to the level of mid of the humerus, shows the motor divisions of the axillary nerve, which supply the deltoid, the teres minor, and the long head of triceps. The sensory supply can be seen in the lower image in blue, which is the inferior region of deltoid muscle. The median nerve. The roots are C6, C7, C8, and T1. The first figure shows the motor supply by the median nerve, which innervates the flexor muscles of the forearm, the thenar muscles, and the 2 lateral umbilicals. The sensory function is shown in the second image. So the first nerve branch of the median nerve, the palmar cutaneous, the supply is shown in blue. And the second terminal branch of the median nerve as the digital cutaneous supply is shown in green. So we come to radial nerve. Radial nerve, the roots are C5, C6, C7, C8, and T1. The motor supply of the radial nerve is triceps and all the extensor muscles, which is shown in blue. The sensory supply of the radial nerve can be seen in figure 2 in different colors. So the first is in green, which is the lower lateral cutaneous nerve of arm. Second is the blue, which is the posterior cutaneous nerve of arm, which is again a branch of radial nerve. Then in yellow, it's the posterior cutaneous nerve of forearm, branch of radial. And the last is the superficial branch of radial, supply the part shown in red. The ulnar nerve. The roots of ulnar nerve are C8 to T1. The motor functions as the nerve's root can be seen in yellow in the first figure are the muscles of hand except the thenar muscles and the two lateral umbilicals, the flexor carpi ulnaris, and the medial half of the flexor digitorum profundus. The sensory supply, which is shown in the second figure by the ulnar nerve, is in yellow, blue, and green. The yellow part is supplied by the palmar branch, the blue part is supplied by the superficial branch, and the green part is supplied by the dorsal branch of the ulnar nerve. So the blood supply of brachial plexus, the brachial plexus is largely supplied by the subclavian, which further gives out the axillary artery and its branches. Generally, the vessels involved are the vertebral, the ascending, and the deep cervical, and the superior intercostal arteries. The cords and roots are supplied by the anterior and posterior spinal branches of the vertebral artery. The trunks of the plexus are mainly supplied by the muscular branches of the ascending and deep cervical arteries, the superior intercostals, and the occasionally by subclavian itself. So it's a little description about the anatomy of the supraclavicular region. In a supraclavicular block, we mainly are targeting the trunks of the brachial plexus. So supraclavicular block is performed in the supraclavicular region. The brachial plexus, while reaching this region, passes in between two muscles, which is the anterior scalene and the middle scalene. And it follows the subclavian artery into the arm while it passes below the clavicle, as can be seen in the figure. The subclavian artery lies anteromedial to the brachial plexus at this portion, and the first rib and the pleura lies inferior to the brachial plexus in this region of the supraclavicular area. So the dermatomes which are blocked while we give the supraclavicular block can be seen in dark blue in this image, which are C5, C6, C7, C8, and the T1 dermatomes of the upper limb. Thank you.
Yeah, thank you, Dr. Pallavi, for that simplified version, revising our anatomy. Now we'll move to our next speaker, Dr. Kala. She's a well-known anesthesiologist, very known for her paravertebral blocks. And she has received many awards, the KOP Best Paper Award at ISACON 2016, GRC Hall of Fame 2017 award. She has many publications, presentations under her belt. She has served as faculty for workshops at the TAS conferences. She also conducts her own live airway workshops. And also she is a co-author for the pocket book of regional anesthesia techniques. So we are happy to have Dr. Kala for our ISA Navi Mumbai clinical meet and looking forward to your presentation. Welcome, Dr. Kala.
Thank you so much. Share the presentation. It was very concise and crisp revision of anatomy. This brachial plexus is always, how much ever you read, you will not remember. So, and supraclavicular brachial plexus block. I mean, it's very much important for the upper limb. Now, thank you everybody I say Vashi for this invite, and I hope I justify that. The credit to sources of images goes to NICERA and internet. No disclosures. This is a photo and video consent form, which I use for to take consent from the patients. Now, supraclavicular brachial plexus block. It's very this is predictable. It is dense. It's easy. It's rapid on onset, and hence we'll go through a little of bit through the history. Okay, in 1911, George Herschel gave the first described surgical approach to brachial plexus in the axilla. Few months later, I cannot pronounce him well, Dietrich Kuhlenkamp from Germany did the first supraclavicular on himself. In fact, he was sitting on a stool, and then he tried it on patients with the patients sitting, and he gave the supraclavicular block just above the clavicle. And in 28, the first publication. So you can see right from 1911, though the brachial plexus was in the axilla was described first, but the first thing was done is the supraclavicular approach in 1928. It was published also, and this popularity of the supraclavicular was unrivaled till they got the axillary approach in 1949. So anatomy has been very well explained by the earlier speaker. Now, where we are targeting is the trunks and the divisions here, just above the clavicle. So this you can see the cadaveric presentation, the thing showing the clavicle, and this is the area where we want to target for the brachial plexus in the supraclavicular block, and this is your subclavian artery here. Okay. Now, in short, the definition. This picture depicts the definition of the LA is deposited in supraclavicular brachial plexus block, just adjacent to the subclavian artery on the brachial plexus, which lies above the first rib, okay, and the pleura is just beneath and lateral to the sternocleidomastoid muscle. So you can see, and from the skin, it's very superficial, okay. So why it is called the spinal? Because in one single injection, it blocks the sensory, the motor, and the sympathetic block is achieved of the entire upper limb. Okay, it was also called as a subclavian perivascular by the Vincent Collins because it's more of a concept. This modification was more of a concept rather than a technique, stating that the plexus anesthesia is performed around a main vessel, that is your subclavian artery. The plumb box technique by Braun and collaborators, this was first described based on the cadaveric and the MRI pictures, studies. Needle is introduced, okay, just above the clavicle, lateral to the sternocleidomastoid, and advanced bang perpendicular to the plexus in an anterior-posterior direction. The needle is inserted at the entry site as if it is carrying a weight, that is a plumb bob, again under gravity. That's the gravitational pull. Okay, so hence it was called the plumb bob technique. But then, if you go outshoot the rib here, you can hit the pleura. No? You can go directly. So this was devised to against the as the incidence of pleural punctures increased, but this was not devoid of indications as in anesthesia and analgesia to the upper extremity below the shoulder. Okay, the entire upper limb. Excellent choice for elbow and hand surgeries. What are the landmarks? The landmarks are the clavicle, the lateral border of the sternocleidomastoid, that's the clavicular head, and here you have to feel the subclavian artery. These are the three important landmarks. The point of needle entry is subclavian sternocleidomastoid muscle, the clavicle. Feel for the subclavian artery, comes around 2.5 centimeters lateral to the lateral border of the clavicular insertion of the sternocleidomastoid muscle and 1 finger breadth just above the clavicle. That is your point of needle entry. What are the equipments required? All the resuscitative equipments and drugs should be ready. The sterile tray for the block should be kept ready. Syringes 20 ml, 10 ml, and 2 ml for local infiltration. If you're doing the block as a sole anesthesia technique, it should be kept ready. And not last but not the least is intralipid has to be ready. The PNS has to be checked for the battery and the patient electrode. 5 centimeter Stimuplex 22 gauge needle is used. You can use any of the drugs above, ropivacaine, bupivacaine, adrenaline xylocaine, or a mixture also. Now, what is the needle direction? Is when you enter, it has to be perpendicular to the skin and then directed towards posterolateral to the subclavian artery. What is the nerve stimulator settings? Initial current you keep up to 0.8 to 1 milliamperes. You can keep it up to 2, but it's not needed because it's very superficial. No need to reduce the current below 0.8 because this is a unique characteristic of the supraclavicular brachial plexus and your lumbar plexus also, that the initial current of 0.8 can be acceptable to for the injection. It's the end motor response that is important and not the low current. Okay. What are the end motor response? Okay, you can get the flexion of the fingers and the wrist, lateral rotation of the fingers and the wrist, the extension of the fingers and the wrist. And these are various finger and wrist movements. You will not get a single nerve, as was explained previously, the radial, the median, and the ulnar or the musculocutaneous, but an amalgamation of all these with wrist and pronator movements too. That is the end motor response. How will you confirm? Pull, push, and pinch technique. What is the position? The position of the patient should be supine with the head turned towards opposite side, the shoulder as low as possible. Okay, you can use a shoulder at the in between the scapulae. The flexion of the elbow and the forearm is on the abdomen. This you can keep it supinated so that you can see the finger movements. Okay, and please attach all the monitors. Now, what is the technique is you use your thumb to feel for the subclavian artery and feel the extent of the subclavian artery, and your point of needle entry is behind that, directing posterolaterally, perpendicular to the skin initially, and then posterolateral to the subclavian artery. That you have to attach all the monitors, keep sedation score. If you are doing the surgery under sole anesthesia technique, keep the sedation score of around 1 to 2 of Ramsay sedation score, and patient can respond. Okay. If you are giving it under GA, please avoid muscle relaxants before the block. Okay. And always check the site before you perform the block. Feel for the clavicle, the sternocleidomastoid, the clavicular head, the sternal head, okay, and then palpate the subclavian artery. What is the depth in depth? Around 0.8 to 3 centimeters maximum, depending on the build, but hardly 0.8 to 1.5 centimeters. You should get the plexus. Volume of the drug needed is around 25 to 30 ml, though I have used as low as 8 to 10 ml drug also. The concentration is around 0.35 to 0.5% of bupivacaine or 0.5 to 0.75% of ropivacaine with or without 2% adrenaline xylocaine as per the dosage according to the weight of the patient. For you have to use higher concentration drugs if you are planning to do it under sole regional anesthesia technique. Now, this is a video wherein the starting current was 2. You can see that the subclavian artery was felt, and hardly 0.5 to 1 centimeters, you can start seeing the shoulder contractions. And this is the brachioradialis contraction you are seeing. The hand is straight, was assisted by the OT assistant. Okay. Now, this is another video. The clavicle, the sternocleidomastoid, the clavicular head, you can see the thumb is kept on the subclavian artery. And as soon as 0.8 to 1 centimeter needle is gone in, you can see the contractions. Okay, you can see a varied contraction, the fingers. First there was flexion and then there was extension. The elbow, see, more medially the needle is turned, so you can see more contractions at the finger end, that is the median and the ulnar, or the stimulation of the lower trunks. And slowly the current was reduced. This is the let go technique. Okay, once you have to get the contractions when you leave the needle also. This shows that you are into the perineural sheath. Okay. Otherwise, you get the contraction, and when you leave, the contractions disappear. That means you are outside the sheath. So you may not get a very good spread of the LA within the. You can see slowly the current is reduced. The needle was advanced, I think around 1.5. This was a 5 centimeter needle. Around 1.5 centimeter was the depth of the plexus, and at 0.7 of the current, this was accepted. And this is another very nice, you can see a myriad of contractions. This is a very good let go method technique. You can see finger extensions at 0.4. You can see the brachioradialis, the ulnar, median, and the radial also. Okay. This is what you're supposed to aim for in a supraclavicular. Okay. Even the pectorals, you can see, are contracting very well. Okay. So all 3 trunks are hit very nicely with the, and you don't need to have a 0.4, you can use a 0.8 or 0.9 current for this. Now, what are the complications? Failure of the block or inadequate action. In spite of getting very good contraction at the lower currents, sometimes you may have an inadequate action or complete failure of the block. There can be pneumothorax because this is the most damage, and hematoma because you are very close to the vessel, especially there can be some anatomical aberrations of a subclavian artery or vein, and you can have a vascular damage or a nerve damage, especially when you use sharp needles. Okay, so preferably always use blunt needles. The 22 gauge Stimuplex needles are very good. The phrenic nerve block, the drug, when it spreads into the scalene muscular groove, the chances of phrenic nerve increases. So is the Horner syndrome, recurrent laryngeal nerve block, and last but not the least is the lignocaine toxicity. But you have to keep your intralipid ready. Now, coming to the failure of the block and why it can occur. As I showed earlier, the let go technique. If your needle, you may get contractions if the needle is just outside this sheath, okay? And the needle is outside, you may get good current and you'll keep the needle there, you will keep getting the current and you'll inject the drug, but the drug will spread outside the sheath and not within. So the let go is very important, okay? So when the needle is inside, you will leave the needle, this sheath will hold the needle. And you have to leave the needle while injecting. That will increase the chances of success of the block. And secondly, this cornermost pocket, this is a lower trunk. The finger flexions, why I told is the finger movements and the wrist movements have and pronation. These three has to be there for a successful supraclavicular block, because this is a lowermost trunk. You can see it is very much close to medial and very much close to the subclavian artery. Okay, so this ulnar sparing is very, or the lower trunk sparing is very common when you inject the drug here. So whenever you get contractions at around 1 milliamperes, and when you do not get the fingers and you want to do it, you have to use high volume block, that is 40 ml or something. But even then, you can have septae within this sheath. So the ulnar sparing is most common when you take end motor response which do not include your finger flexions. Now, this is one video which I want to show. The needle was flushed before so that the air electrode was attached. The point of needle entry was marked. See, this was a upper end humerus. Okay, very nice movements, but the I just accepted this because the contractions were present even at 0.28. Okay. But what you're seeing is the more of upper trunk contractions. And this patient had to be given an interscalene block also because the supraclavicular completely failed. Okay. So sometimes when we see these contractions, we get very much excited and seeing at 0.2, we think we can get away, but for a proper success, you need finger movements, wrist and finger and wrist movements. Okay. So the highest success rate is associated with finger flexion response. The sparing of ulnar, that is what I showed was the lowermost and the medialmost trunk leads to the failure of the block. The lower trunk response, hence, is a high success, that is flexion of fingers, wrist, or pronation of hand. Okay, end motor response is more important than the current. So do not, even if you get this response at 0.8, 0.9, or 1, please accept it. It will be a successful block. If you get ipsilateral diaphragm contractions, the needle is too medial, you have to withdraw and come out. If there is trapezius contractions, the needle is too lateral, you have to direct it medially. What is the effective dose for minimum effective anesthesia volume? They have studied and they've come to the ED50, where the 50% successful block is around 23 ml, and for 95% successful block, the volume is around 40 ml. Volume is, they have seen and studied for the USG guided and the non-USG guided location of the brachial plexus. The volume remains the same, but I have used supraclavicular block for along with my paravertebral block to block the lateral and medial pectoral nerves and the nerve to the serratus anterior and latissimus dorsi. A small dose of 5 to 8 ml also suffices there. Minimal effective concentration is around the 0.3 to 0.5 bupivacaine and ropivacaine. Lowering the concentration leads to increase in volume for the successful blocks. If you reduce the concentration, you may have to get higher and larger volume. Around even 0.1% of adrenaline xylocaine has been successfully used, but the volume around 25 to 30 ml. Phrenic nerve block with supraclavicular block is around 67%. It occurs more if the LA is spread into the intermuscular groove, okay, between the both scaleni. Reducing the dose and the volume reduces the chances of phrenic nerve block. For pneumothorax, to avoid pneumothorax, you have to remain lateral to the anterior scalene muscle. You remain away from the first rib. Never go below the clavicle. Okay, keep your needle tip above the clavicle. Never go below the clavicle into the first intercostal space. Divide for an easy direction, divide the clavicle into 3 parts. The medial third is the attachment of the sternocleidomastoid. The trapezius is your lateral third. The middle third is your neurovascular bundle. Suppose you cannot, a patient is very obese, this division of 3 parts remains the same. So go by the middle third for the brachial plexus. Now I have completed this. The limitations of supraclavicular is that the tunicate pain can be there when you are using a supraclavicular so you have to infiltrate along the tunicate level for relief of pain for tunicates. This is a pocket book which is which I had co-authored, and a simple, easy reference book in the OT. It's available at National Book Depot or Amazon. Thank you.
Thank you, Dr. Kala. That was really the minute details and description you have given, and surely it will help us in our daily practice and the success of the blocks. The video is shown nicely, the contractions, which will also help all the practicing anesthesiologists. Any questions? I request all to put in the chat box so that we can take it later. And now coming to our next topic. Regional anesthesia has evolved from the landmark technique to present-day USG guided blocks. So our next speaker, Dr. Sweeti Purushottam, will explain us the basics of USG. She is the assistant professor at DY Patil Hospital, and she has done fellowships in pain and in regional anesthesia and trauma. And she is also the mentor for many in many programs for the regional anesthesia. So I welcome Dr. Sweeti to take over and give your talk.
Good evening. Thank you for welcoming me into today's session. I'll be sharing my screen. I hope it's on screen now.
Yeah, it's there.
All right. So good evening, and back to what the the latest technology that we are into. The journey of regional anesthesia has started from a very humble start, and we are still evolving, and it is still very interesting that we have a lot of newer technology and a lot of tools in our anesthesia specialty, that the field seems very vast, and it's always something new every year. So now, talking about the basics of ultrasonography, let's see how the journey of ultrasound had started. So look into a brief history. Now, whatever I'm saying is something that I've derived from radiology books, from regional anesthesia textbooks, NISORA, and the pictures are from internet. So that's my disclosure, there's nothing else. About ultrasound, initially when it was found, it was not the ultrasound that was discovered first. Query actually discovered piezoelectric crystal property in 1880s, and eventually after a century later, those ultrasound waves which were used by Navy to find submarines or in the warfare. So eventually what we saw is more than a diagnostic tool, medical usage was initially in the therapeutic. So they used to use it to treat manias, they would use it to treat conditions like arthritis, and eventually the ultrasonography progressed to abdominal ultrasonography for gynecological conditions, obstetrics, and then it went on spreading for regional anesthesia for different kind of diagnostic purposes. So moving on to there seems to be, okay. So moving on to different applications that we have, it's quite interesting that it is not just regional. We have a lot of other procedures, even chronic pain, which I'm more focused on. We use a lot of it. There is vascular access or central line access that we use, which is very important and medico-legally safer nowadays. Airway assessment, lung ultrasound, ultrasound for monitoring, gastric ultrasound, TE, which is even more advanced if you need to understand cardiac anesthesia. But the focus, since today's session is on regional anesthesia, let's move on to how we apply the physics of ultrasound for it. Why ultrasound? In the past 20 years, ever since Sonosite has been improving and giving us portable ultrasound machines, it has become much more easier and much more advanced ways of understanding where all we can use ultrasound. So these are the latest areas that we have been using. It is point of care ultrasound, where you can use ultrasound on any emergency setting or any place that you actually need to use. There is bedside sonography that you can do for immediate diagnosis and correspond to your clinical conditions. So this ultrasound probe is replacing as the most important tool in our kit. It has almost become like a stethoscope for us. This is echoscope that you can see around. Now, why ultrasound in regional anesthesia? Yes, we had peripheral nerve stimulator, but there are some additional advantages that ultrasound gives. It gives a real-time imaging. It helps us in visualization of neural and vascular structures. And also whenever the block, because we know where the block drug is placed and the spread is done, we can target the area, and there is faster onset and more accuracy for this particular block. And the volume required is much lesser. Now, what is ultrasound? Let us go to the basic physics. What is sound? Sound wave is a mechanical energy which is transmitted through a medium. Sound needs a medium, and this propagates through the deformation of an elastic medium. Now, there are different wavelengths that you have to know of. If there is diagnostic ultrasound frequency that we use is 2 to 15 megahertz. Sometimes there are places where even 40 megahertz has been used. And the sound that we humans can hear is from 20 hertz to 20,000 hertz. So how do we break down this? If you see, there is sound, there's infrasound that is below those levels, and there is ultrasound, which is above. Now, the audible frequency is between 20 hertz to 20,000. If you see, the one below 20 hertz is infrasound, which in nature elephants can actually hear. And the one above 20,000 hertz is something that ultrasonic waves or sound waves are made, which bat can produce and receive. And the medical ones, we have already seen the frequency that we use. Now, the very important discovery that led to us using ultrasound is piezoelectric crystals. There are cords. The ones that we use is lead based, and there are more inventions which are going towards lead-free crystals to be used. Now, these piezoelectric crystals are placed parallel on the probe in an array of 100 to 300 crystals, and that's how they. Now, what is a basic mechanism? You have the ultrasound machine which is connected, or you have an electricity which is passed on through the transducer, and it will create a mechanical force on the crystals, agitate it. This mechanical one will create sound waves. That frequency is propagated further through a medium. And then whatever reflected waves, it is taken back. Again, the piezoelectric crystals correspond, they expand and retract, and then pass on this mechanical energy as electrical energy back where the ultrasound machine detects and forms an image in the form of gray dots as a grayscale image. Now, depending on the thickness of the crystal, you can understand whether it is low frequency or whether it is high frequency. Now, why do we see different kinds of colors in black? Shades of black, shades of gray, shades of white, because it depends on the kind of structure or a medium that it passes. So if it's fluid, it allows the waves, it's a good conductor, it allows the waves through, the sound waves through. So it is black or anechoic. Then soft tissues, it is hypoechoic. And bone. Now, bone, what it does is it reflects it entirely. Or so you can see a white structure. So this is how you differentiate different structures. More in detail. So when we have arteries and vein, you can see there's a black shadow and then there's a rim of white. Now, if it is compressible, it is vein. If it is not, it is artery. And then depending on different structures, muscle, it is heterogeneous. So you will get a mix of hypoechoic with hyperechoic. Whereas bone, you will get a very hyperechoic. This is how the bone part, white, it would appear white. And nerves, again, it depends on where the nerve is placed, the surrounding tissue. So you need to really understand what are the surrounding structures and how it reflects. How do you differentiate between the different echogenicity? And this is isoechoic. That means it matches with the surrounding tissue. And when it varies, then you tell it is hyper, hypo, anechoic. Now, we have seen piezoelectric, we have seen the different kinds of shades of image that is formed. Now, what is a transducer? Transducer, it is something like a microphone as well as a receiver. So it also emits and it receives. And this is very vital tool to understand and diagnose the image on the screen. Now, these are the different kinds of transducers that we commonly use. You have a linear probe where the piezoelectric crystal is placed linear, then there is curvilinear probe, and there is phased array. Now, the commonest ones we use is linear because most of our peripheral nerve blocks are superficial structures. So this is a high frequency probe which will allow a good visualization, a better resolution of the superficial structures. But you wouldn't get that depth because the more higher frequency waves go, the more it gets absorbed by the tissues earlier. Whereas in curvilinear, it is a lower frequency probe. So there is more penetration, but the resolution is not as good as the linear probe. But this is used for deeper structures. And if you see the hertz, most often this is between 4 to 13 hertz, megahertz, and this is a lesser megahertz because it's a lower frequency. And this one is used for tight structures or small surface area like ribs. There's also one more probe that we don't use it unless required, that is hockey stick or J-shaped. It is used for pediatric or finer structures. It also is a high frequency probe. Now, different kinds of ultrasound waves that we get is when you place the probe, and if it is sending back, right, you get a reflection. Normally what happens is there's a medium, a liquid medium or a gel that you place in between, and it is propagated. Now the wave should go straight forward and it gets absorbed. Absorbed means there is heat that is generated. It gets absorbed by the tissue. But in some cases, there is dispersion because of rough surfaces or heterogeneous surfaces. The waves get dispersed in, or it is scattered in different directions. It is very vast and complex, the physics, but it is very simple also if we understand the basic rule of how light or sound wave gets transmitted through the different materials. Similarly, refraction. Now, not all structures will be right under your probe. You need to move angles, you need to change angles. So your alignment won't be in the same line. It will be in different angles. So you get a different refraction. You need to understand the different kinds of image that will be formed so that you can differentiate different structures. Basic, simple thing you need to know is fluid. It gets transferred through. In tissue, sometimes some are absorbed, some come back. Whereas bone, it doesn't absorb complete at all. It reflects. And air also, it's the same. It's not a good conductor. Now let's use the different modes that we know of. A mode is a simpler mode where you get a singular wavelength. It's a single wavelength that is used. The one mode that we commonly use in regional anesthesia is B mode. It creates a 2D structure, two-dimensional structure. So it gives a better visualization of the required anatomy and visualization of structures. Whereas M mode is a movement mode, right? So in that, you can, suppose if we are using it for T or we need to see a valve movement, we normally use that. So it's a combination of 2D as well as there is a movement that is recorded of the valve. So you get it in two different modes. There's a waveform that is formed. And then there are Doppler modes where you can choose between a non-directional or a directional. Color mode helps you in understanding the direction of the vessel. Sometimes you need to understand, there are vessels that you do not differentiate between different structures. You need to make sure if there's no vessel in the area that you want to perform the procedure. So then you can also use the aid of color mode. So color mode, if you see, now the red and blue doesn't denote according to the artery or vein. The red one is towards any movement of the fluid in the vessel towards the probe, it is in red, and away it is in blue. So that's how you differentiate, but it indicates the vascular structure or the movement in that. Now, before you perform a block, it is very important that you go through the manual of your ultrasound machine, depending on what the company has given about its safety features, about the usage, and about its troubleshooting, because it is important to understand the tool you use. So most often we have to know on-off button, we have to know this depth buttons and zoom. This is also important, the gain buttons, This is your trackpad where you'll move your mouse, and these are for your patient history recording. And this 11 number, it is your color Doppler. And if you see this, there's one important button the assistant always has to know, because you'll be scrubbed in with sterile gloves and you won't be utilizing the knobs that often. So freeze image and how to anti-freeze it. That is one important button. So now we have seen the different kinds of frequencies. Now, yes, when you're using ultrasound, you do know how an in-plane technique and an out-of-plane technique works, right? In-plane is along the side, you see the entire length of the needle, and out-of-plane, you'll be going from the midpoint out of the probe. So in this case, you will get artifacts which are not your regular image. It is something different from the actual image. So the common ones you need to know is reverbation, mirror image, and isotropy. These are the ones that can cause abnormal images, and you would be confused whether your needle is actually placed or not. So if you see this waveform, now whatever we are performing has to be under this waveform. It's about 2 mm size, so you need to perform under that. Now when you see if there is something that doesn't pass, so there's a shadowing that is created, and there are some images which is reflecting refractions. If you see this, yes, when the image when the wavelength frequency, it hits the needle and bounces back, it again hits, bounces back, there are reverberation artifacts. This is how the shadowing looks through. And there are some areas where there is thickening, all right. Below that, you might not be able to visualize. If there is a bony structure, below that bony structure, you wouldn't be actually be seeing what is under this. So you need to change your angle. You need to align your image so that you make sure you don't create any mistakes. Always do it under direct vision. Now, when we have spoken about what we have been doing and how is the future in ultrasonography and radiation anesthesia, now there are more portable ones. There are handheld ultrasound probes that have come in, which can be connected to your mobile phones. It can be connected to your tablets, or there is a detachable screen that comes with it. There is 3D ultrasonography, there is 4D ultrasound. But those imaging is still not in common use, but it has come, and it is much more important that we understand the future is already here. We need to make it our friend, and whatever all we have been trying to tell is you need to adopt better imaging methods for your blocks. You need to plan your needle placement so that you don't do multiple pricks and displace a good field. So it is important to get a good image prior to performing the block, and always practice safety. It is utmost important that you are able to do that. And that's, thank you. So whether it's a color Doppler or whether it's a black gray scale, it is very important that you know your anatomy well, because your brain does not, unless your brain knows what it is looking into, your eyes won't see it. So happy, safe practice. And this is how we say in racing, it's precision and safety that we follow. Thank you so much.
Thank you, Dr. Swiki. It was nice for us to know the basics physics of ultrasonography, and it will help us a lot. With this knowledge, now we will move to our next topic, which is USG guided supraclavicular blocks by Dr. Dilesh Kadu. He is the head of the department at MGM New Bombay Hospital, Vashi, and he has special interest in regional anesthesia and ultrasound guided blocks. He has pioneered USG guided blocks in MGM New Bombay Hospital and has been practicing it since 10 years. So now, welcome to our speaker, Dr. Nilesh Kadu.
Hello everyone. Can you hear me and see the screen?
Yes, yes.
Yeah, thank you. Well, just a minute. So I'll be talking about ultrasound guided blog. How can I hide this? Okay, fine. So my job already made easy, excellent way by Dr. Sweetie and Dr. Kala and our fellow student. So starting directly to ultrasound, you all know the advantages. Rather than going too much into detail, in short, it gives us a direct visualization of nerve, and we can see spread of local anesthetic in real time. So advantages over the landmark is that you can see for any anatomical variations. Thus, you can avoid the complications like intraneural injection. Rapid onset of block we can get. We can reduce the dose requirement, and most importantly, improved patient satisfaction and excellent surgical anesthesia with minimal side effects and complications. Now, you must be wondering why I have kept this slide. Let us make few things very interesting because I prefer memorizing things in a different way. You must be seeing all these are grapes. But in this picture, you see grapes with bag. Then you see this picture where you need to identify dogs in this black and white picture. And then our master blaster, Sachin Tendulkar, playing with the straight bat and connects in a proper direction. Now coming back to our core area. So basically, rather than calling it as an supraclavicular nerve block or directly a brachial plexus block, I would like to mention it as a sheath block. Now, future will be the era of all facial pain blocks rather than individual blocks, and our aim is to block the nerve, block the area around the nerve rather than nerve itself. So, in this subclavian perivascular block, the name itself suggests that there is some sheath which is formed by the two scalene group of muscles. Like in front, we have anterscalene, and the posterior side we have middle scalene. The posterior part of the anterscalene and the middle part of the middle scalene, or anterior part of the middle scalene, the perimysium of that forms a sheath which also include the subclavian and plexus. The trunks of the plexus passes through that. That's why we called it a sheath block. Now, our aim is to block mainly the three trunks of the plexus, and the best area which we get is at the first rib. So just to memorize for the students, basically for novice practitioner, this apple like a subclavian artery, grapes or bunch of grapes, and this is the rib. Now more detailed presentation, if we go by anatomical dissection, you can see the artery, plexus, sheath, and the rib. By sonoanatomy, you can see the subclavian artery, pulsatile, the rib, straight rib, and the plexus covered by sheath. Now, when to block and when not to block, that is really, really important. When to block, we all know the indication is common, any surgery below mid-humerus. And when not to block, the contraindications, whether it's absolute or relative, it's common for landmark technique as well. But as far as ultrasound techniques are concerned, I would say if you are not trained in ultrasound, preferably don't go with the block. Get yourself trained because it looks very interesting and quite alluring, but it has certain learning curve. So better to get trained with experts, and then you should start. Now, one need to be careful about discipline perivascular block. One should see whether patients have any reduced respiratory reserve because of any flail chest or COPD or something like that. Any previous neck surgery or head neck radiation that might have deranged the patient's anatomy, because earlier I have mentioned it's a sheath block, and the complications can be your technique dependent or a volume dependent. So there could be a deranged anatomy because of previous surgery and the radiations. Now, cardiac compromised patients is really important to look after, because in many patients, the request comes from surgeon that patient has low EF, patient has so and so cardiac issues, will do under block. So, though it is very useful in such kind of patient, but there is some reason for to look after for the cardiac compromised status of the patient. I'll come to it later. Now, if you have other fractures with this kind of block, you need to see whether you have calculated your dose and volume properly. And there is a subconscious tendency about a decreased level of vigilance when we are giving block, whether it's a landmark technique or any other technique. So your level of vigilance should be the same. The problems could be because of phrenic nerve, as Dr. Kala has explained very well. Recurrent laryngeal nerve, you can have a hoarseness of voice, then you can have a Horner syndrome. Then there could be possibility of cardiac reflex blockages. You must have heard about BJ reflex in first physiology, like Benson reflex. Volume dependent, there can be a volume dependent spread of the local anesthetic into the carotid sheath, as few studies explain that carotid sheath is not intact. There could be certain sheath-like openings, and that drug can block the carotid receptors. So one side of the carotid reflex gets blocked, and so there will be a hyperactive reflex on the other side. So there can be a complications like bradycardia and a significant amount of hypertension within 30 to 40 minutes of blocks. So that's why I have mentioned, and in cardiac compromised patient, this is really important. Now, it could be pneumothorax, which is very rare in ultrasound, and it could be a technique dependent like intravascular spread. Now, preparation. So how we usually go ahead, thorough PAC with informed consent. During PAC, we rule out all the respiratory disorder, underlying palsy, cardiac status, allergy, LA assessment, the local site assessment. One should actually see the fracture bone X-ray and discuss with the surgeon, because it is very important to know the myotome, dermatome, and the osteotome, which approach surgeon will be taking. Then pre-medication. Now, pre-medication, as Dr. Kala has explained very well. In a simple word, it should be adequate enough to reduce the anxiety and the initial needle precaution. But it should not be too much to obscure the needle injury because of nerve puncture. So that much amount of sedation should be titrated with the patient. Ultrasound machine, high frequency linear globe, sterile sleeve. Local anesthetic, we try to limit till 20. The combination we usually use is 2% lidocaine, the adrenaline 10 cc, 0.5 bupivacaine, and as an adjuvant, preferably dexamethasone. Needle is 24 gauge, 1.5 inch needle, 10 centimeter extension, and syringes with sterile use. Now you can see there should be a good amount of lubricant jelly. We cover it with the Tegaderm and 10 cc syringe for LA, and 2 cc or 5 cc can be used for novice practitioner who want to locate the needle or do hydrodissection. It is really important, but as you get expert, you can avoid that. Now, there should be a checklist other than your W2 checklist. Many centers have a checklist or a screen kept on the ultrasound machine, like a stop before you block. You identify the patient site, and then you go ahead. Now, position is usually supine or semi-sitting. Many literatures have mentioned lateral also, but the most commonly used is arm adducted, and there should be a pillow below the shoulder, and head turned to the contralateral side. Now, ergonomics. So why ergonomics is important? It is really important for have a better visualization of the structure, because our ultimate aim is that we should be able to see the neural structures properly, and we should have a real-time visualization of the spread of the local anesthetic. Now, poor ergonomics can be because of if you are turning your trunk, you are holding the needle in the wrong hand, turning your head to 45 degree. Now, this is the commonest source of error for fatigue and poor performance, and so as the failure of the block. Now, why right ergonomics is important? I was just scrolling through the Google images, and you must be seeing the master blaster Sachin Tendulkar. He is having his head, bat, his pad, and the ball in the same line of action. And the result of wrong ergonomics, you can see. Then I have searched for a top 5 best batsmen in the world. Then I saw everyone have best ergonomics when they are playing. In our case, it is different. It is in fact the same as like great players do. Here you have a monitor in front of your face, operator standing on one side. If you are holding a transducer in the same axis, and if you are going through a in-plane technique, so your eye, your hand, shoulder, and the screen should be in the same plane. If you are holding the transducer in a lateral plane and the needle is going in the same plane, but your eye and shoulder, everything should be in the same. Now, in this case, you must be seeing I am holding the probe with right hand for left using a needle puncture through the left hand. My assistant is holding the needle, syringe, and my eye is on the screen. It's in the same plane. I'm placed myself obliquely, but in the same plane. Wrong ergonomics, you can see. These are the examples of wrong ergonomics. Now, you are good at ergonomics, like a best batsman in the world, but now you need to think like an aeroplane pilot, because you need to land somewhere on the runway. Our runway is our trajectory, our target is our nerve plexus, and we need to have a scout scan before we land. So like any aeroplane pilot, you should do a scout scan to see any variants or anomalies before you needle it. In this case, you do color Doppler, see the anomalies, and when you get a best image, you think. Now, routinely, what we get, we conventionally is knowing that subclavian artery in the sheath and the plexus, but this is not the case everywhere. You just go through the literature. There are numerous vessels originating from the second part of the subclavian artery or a thyrocervical trunk. There could be a transverse cervical artery, suprascapular artery, or a dorsoscapular artery. Cadaveric dissection shows, you can see here dorsal scapular artery is going above the upper trunk. Here it is going between the middle trunk and the lower trunk, and here it is going below the middle trunk. So we must be aware of all these things. No need to know all these things in detail, but one should be aware of all these things. Now, here you can see dorsal scapular artery. It has almost bisected the plexus, the upper and the middle trunk here and the lower trunk here. And this is a vessel and artery coming through this. So how to block this? So you should be knowing, if you are going by out of plane technique, I prefer going above the artery with the good aspiration, confirming the negative aspiration of blood, and then the below the artery. Now here you can see transverse cervical artery going above the head of the plexus. But so why it is important to know all these arteries basically? As we all know, it is a sheath block, and the success or a failure of the block is really depends on these vascular anomalies as well. Many times we had given enough amount of local anesthetic, excellent spread, but because of all these vessels, there could be a restricted spread of the local anesthetic to different trunks, and that results into failure block. So we should keep all these things in mind. Probe placement, conventionally it's a coronal oblique plane. You just keep probe parallel to the clavicle just behind it, or routinely which I follow is a modified parasagittal technique. You turn the probe in this plane. In coronal oblique plane, you keep a transducer parallel. You have a stable location, but only a first part of the only the part of the first is available or visible, and there are chances of plura as well. In case of modified parasagittal plane approach, it is get posted to the clavicle. You get perpendicular to first rib, subclavian artery, rib, and the corner pocket can be easily seen. Now, our aim, we all know that the first rib is not the straight, but on sono anatomy, we are supposed to make it straight. So this is the main point everyone should understand. So you have your image. Now what to do? You just see the depth. You can adjust your focus again and press the probe, see veins, artery. Veins are compressible, arteries are not, all these things. Then when you finalize, you plan to target. Now where to target? That's why all this picture I have kept. We all know, or conventionally everyone think that it's like we have been taught conventionally it's a bunch of grape, we need to target it, but it's not the bunch of grape. We need to target a sheath of a grape. That's why I have kept this image to easy to remember to all the juniors, that we need to instill the drug inside this bag. Do not puncture the grapes. Be careful about, we have a tendency out of excitation, once you get the image, we have a tendency to probe and just blow the plexus like a grenade. Do not do it, just stay outside the sheath. Approaches can be in plane approach or out of plane approach. Usually we prefer out of plane approach. We held the probe in left hand and the dominant hand is using the needle, and out of plane technique. You approach your upper trunk, middle trunk and lower trunk. Usually upper trunk, middle trunk are in a common sheath, common septa inside the sheath, and the lower trunk usually we get in the corner pocket. Now, one should recognize and appreciate the pattern of spread. If it is intraneural, patient will feel pain. That is the reason for avoiding deep sedation, as I told earlier. There could be a resistance during injection, so your assistant need to be excellent and should be used to, you should keep a routinely common assistant, because he should be thinking the same plane as you. Never ever give preferably a syringe in hand to technicians, because they don't appreciate the resistance. And if there is expansion of nerve, it is definitely inside the nerve bundle. Now, all these structures are very much mobile. You can displace either by hydrodissection method or gentle needle probing and tangential approach can help you getting through all these structures. Always aspirate every 3 to 4 cc and look for the blood at the needle hub rather than at the syringe level. So any absence of visible fluid spread, always think of whether your needle tip is not visualized. It could be intravascular injection. So how to pierce fascia? Do not jab it. You just advance in a controlled manner. Aim at a tangent to the surface of the nerve and pierce fascia some of a distance from the nerve, and ask your assistant always to inject very gently and slowly. So detailed anatomical knowledge is extremely important, because you see what you look for, but you look for what you know only. So your anatomical knowledge is extremely important, and you should train yourself for all this kind of pattern recognition. And the last slide, though you scan in 2-dimensional, you should always think in 3-dimensional. Unfortunately, I was not able to upload the videos. Next time I'll definitely try to do it. And this is the end of the my session. So take a message, that's it's a sheath block. The commonest cause of failure, missing the corner pockets. We have a tendency to avoid the first strip. So people usually are scared of hitting the first strip and getting the corner pocket. That is the commonest mistake we do, and the reason for failure of block. Another cause is the as I said, arteries bisecting the plexus, and ergonomics is extremely important. As I trained you, you should have told you you should have a trained assistant, and get yourself trained in a plan B block. Like if you have any problem with the this subclavian perivascular, you should be able to use a infraclavicular or a axillary block. And the level of vigilance should be as good as GA. There could be numerous complications, as I earlier explained. And always document, talk to patients, relatives, your consultant, and document the reversal of block as well. Tell your patient that your limb will be heavy for so many hours, and document the nerve plexus problems or any damage prior. Thank you.
Thank you, Dr. Nilesh. That was a very lucid, informative presentation, and it will surely help. Your practical tips will be helpful. And now we'll go to the questions, if any.
There's one question for Dr.
Doctor,
Kala.
yeah. Yes, Olvina ma'am.
Yeah, there's one question in the chat box for Dr. Kala.
Yeah. Yeah, Dr. Kala, the question is from Dr. Neelam. She's saying you accepted twitches at point 2. Is there any chance of nerve injury there? And if the block failed, she is asking after how much time and what volume would you give?
Yeah, I had actually mentioned there. Can you hear me?
Yes, Dr. Kala.
Yeah. That the minute the contraction comes, everybody is excited and we give the drug. I thought, okay, I'm getting the contraction at point 2. I withdrew the needle tip little bit outside and adjusted at 0.34. And beyond that, the contractions disappeared. That was the Raj technique and everything accepted. And we injected around 25, 30 ml. But there was absolutely no this thing. They started giving position, thinking ki the action will come, We start telling the patient ki aega 5 minutes see what, and then 20 minutes later I realized ki this is not working. And then I repeated again with an interscaling 15 ml after 25 minutes.
Okay. So there is one more question. Is from Dr. Jayashree. How to explain the block complications in patient's language and consent? Any one of you?
Can I answer this?
Yeah, sure.
Yes,
Definitely.
yes.
Actually, I must tell you, my experience, many surgeons tell a patient that you have so many problems and will be doing this surgery under local anesthesia. So many times patients come, relatives say, yeah, doctor said, aapka local mein ho jayega. So they are not at all aware about the blocks. So you should explain during your PAC different modes of anesthesia, like regional anesthesia and general anesthesia, and explain your block in detail with its advantages over GA. And I usually tell patient that you'll be able to eat early. So that is a most alluring thing for the patients. So secondly, I tell them obviously compared to GA, there are less complications, but these are the complications depending on the technique used and the type of block. And we don't explain too much. We just explain a few things, but at the same time, we say that we have a 99.9% success rate as far as possible as our experience is concerned. So that reduce the patient's anxiety. As we all know, explaining too much in detail is like losing the patient and later the surgeon also. So after the complications, like I had seen hoarseness of voice, I had seen the heaviness of limb for more than 14 hours, then diaphragmatic paralysis, and the obtundation of BJ reflex also. After 30 minutes, there was a bradycardia with hypertension, which was really unexplainable at that time. So that can be explained to the patients, hoarseness of voice or your vocal cord palsy also. But if you assure the patient that it will get reduced, you document, talk to patient's relative, and continuously communicate, that can be taken care of. In few of the patients, there was a neuropraxia, which we all know it gets settled within few weeks. And the second question is that second question was, yeah, patient's language and consent. So you should explain the blocks, pros and cons, everything in detail to the patient, and assure them that we have a best team available and we are able to take care of all the complications which are documented, which are very rare actually. So patients are quite okay with that. If you tell them we have a teamwork and we are able to handle the complications rather than hiding the complications.
Okay,
Also
so
depends
any
on
more?
the kind of patients that we receive. Some patients are too educated. Some do not understand what is happening around them. So there are a lot of other factors, and some come asking for block itself because they are scared of being sedated or not knowing what is happening. So there are all kinds of patients that come to you. Now, depending on how they are, you need to gauge and make them understand. Yes, documentation is very important because sometimes you get with crush injuries, with nerve injuries already there, or even the old fractures with nerve injuries. Despite that, you still do blocks after proper documentation. So yes, once you disclose it to the patient that it is like any other routine procedure, and we have chosen this because some patients don't understand the difference. If you just give options, you have to tell them what is a better option depending on what surgery it is. And as usual, whether it is any thing to do with any medical procedure or either otherwise, even if you're in the ward, there's always some percentage of risk which is either disease related or it could be even a vasovagal, right? People are afraid of needles, so we are prepared for it. At the same time, they have to be assured they are in the safer and safer hands and a place that is appropriate to handle all kinds of complications. That's about it.
Can I ask one question?
Yes, sir. Yes, sir.
Yeah, I just wanted to know, any freelancers in your area are using USG for peripheral nerve blocks, or do they have any access to USG? Freelancers, I'm asking.
The access is there because most of the hospitals have USG, but are we permitted to use? So we cannot, even though if we are using, many of them do not document. So supraclav easily people are giving, but they are not documenting the usage of USG. Hello.
So you all have access to it.
Access is there. Most of the multi-specialty nursing homes for freelancers, you mean, or if you go to a setup semi-corporate kinds of, so most of them have a sonography. Only the gynecs do not have the linear probe. But with the vaginal probe also, you can give supraclav. You can see the vessel, only the window is very small. So best way to do will be the dual technique. So that, but USG is available. For upper limb especially, you can take the, in small setups, they do not allow you to take away the sonography machines.
That's right.
To the,
Exactly.
yeah. So for upper limbs, it is easier that you can take the patient to the sonography room. That's how I do. I take the patient is blocked there in the sonography room, and then we make it as a block room. And then the patient is taken to the OT.
Then technically we should have all the resuscitation available in the block.
Yes.
Any idea what is the cost of the handheld ultrasound machines which are in the market now?
We are not allowed as of now, so we would not go into that area. Once the law is permitted, maybe we can talk more about it.
Oh yeah, so it's
That would be my dream. What do you say to have?
Yes.
Yeah.
yeah, exactly. I mean, that is the future, as you said. I mean, that's the future of a modern anesthetist now in the 21st
Actually,
century.
ultrasound has made our lives so easy. But it will be more useful in freelancer practice, but because of law and other issues, it is difficult. So let's hope.
I hope our society goes ahead and tells them it's a very important, vital tool for
Absolutely. I mean, they should,
and
I
get
think
law reform.
yes, we
What
should.
are the 2D eco specialists are doing? They do have mobile portable ultrasound machines which they carry in all small setups, do the 2D echo of the patient and then move on. They do have PCPND license also, but they are very easily doing it.
But they can specify that they're doing only 2D echo. We use it for the entire body.
But we are not doing it. They must be saying they are not using where we are using for obstetrician.
We need facial blocks, abdominal plane blocks, pelvic region.
Okay.
So we'll avoid that.
No, there is no guarantee. No? See, for us, if you see the whole society as per se, when I've gone n number of times for application as a freelancer, they are saying that your nerve blocks are the least important for us. The female feticide is so much in the rise till now, and they have quoted so many doctors going for abortion. After what about the uneducated? So they are saying it's a very impending, big task for the authorities. They don't want
Dr. Kala,
one more group of doctors doing this.
No, I agree what you are saying, but how come 2D eco specialists are getting away with it?
No.
There must be
2D
some.
echo
There
is
must be
also
some.
not getting away with it. They have to enroll the name. It is very strictly monitored. The hospitals are not taking any chance because they have to give these reports. They have to submit, or their things will get cancelled. Their sono machine gets sealed often. So these things are not easy, and unless there is no gynec work. Suppose I know orthopedics who have got sono machines, and they have got mainly permissions for their anesthetist, because in ortho setups it gynec work is not coming in, so they get easily the permission.
My suggestion is that till this regulations government allow and everything becomes as we expect, especially to all the freelance practitioners, get yourself trained with the ultrasound, because it has certain duration of learning curve.
Yes.
So your hand-eye coordination takes time. So
in the meantime,
you just go to the best center available and get trained under best of the hands. And I hope within a year or then we should be able to
keep using the probe. See, and it improves your PNS. That's what I can say. Ki learning sonography, people are not coming forward. Ki this is of no use to a freelancer. So why should I get trained? Why should I spend so much time and money on this? But going for repeated sonography training has given me a 3D image for my PNS and LOR blocks also.
Exactly.
So the success rate with the PNS, in fact, my PNS comes as close to the sonography as possible.
Exactly, same as I have experience actually. Earlier, I was not that good at landmark techniques. After ultrasound, I got some 3D image.
Yes.
As I explained, and now I am able to get to the landmark technique very easily. So that helps, like a reverse learning.
Yes.
Retrograde learning. So you can do that.
Yeah. Any more questions?
Yeah, I think now no more questions. So we'll come to the end of our clinical meet. And I request Dr. Tarin Mittal, sir, our treasurer, to give vote of thanks.
Everyone can hear me, I hope, because I was having some problem with the audio. Can you hear me?
Yeah, we can hear.
Yes, sir. Yes, sir.
So, well, coming to the end of the session, and because I hope everyone enjoyed the CME as we do nowadays. And I am Dr. Tarin Mittal, freelance anesthetist in Kharghar, Navi Mumbai, treasurer of ISA Navi Mumbai, and this opportunity is given to me to give the vote of thanks. And I would really, first of all, thank Dr. Reena Gautam who has anchored this program wonderfully, and along with her, of course, all of you who have participated, all the speakers, starting with Dr. Pallavi Goyal, who gave us an excellent description of the anatomy of the brachial plexus, which all of us, I think, had learned during our MBBS days, but have forgotten very quickly as private anesthetists, and Dr. Kala Ishwaran, who gives such excellent supraclavicular blocks. I love the historical perspective of the block, which started back there in 1911, 1927, the history of it. Yeah, and I think she has written a wonderful pocketbook, which we should all carry, actually. Thank you, Dr. Kala. And Dr. Sweetie for making us understand ultrasound, and which is so nice, because this is going to be the new anesthetist. I think I just read it in Times of India just a couple of days back, how ultrasound is going to replace stethoscopes. Just as in the 16th, 17th century, physicians used to listen to the heart sounds by the ear, and stethoscope was invented, and everyone thought, oh, everyone is going to lose their clinical acumen back there in the 17th century. But it didn't happen. Stethoscopes came and doctors used. So also ultrasounds are going to replace this. That is the future. And finally, Dr. Nilesh Kadu, who's an excellent ultrasound specialist, supraclavicular block specialist, I would say. And well, I see. I love the examples of the apple grape image and Sachin Tendulkar's image of the right approach, and I think that's good for everybody, and it's wonderful. So I'd like to thank the questions which were put by the viewers and everybody who came and listened to the whole supraclavicular block CME, which was hosted by us at the ISA Navi Mumbai chapter Anesthetic Society, and we especially Dr. Jesse, and Dr. Alvina, who are in the forefront of making this happen. And I'd like to give my regards to I think Surekha Patel madam, the senior person, I hope listened to our lecture, and I think Dr. Jagtak madam, I think also joined in, and besides, of course, the viewers who all over from the world. I hope somebody from all over the world watched also. So I'd like to finally thank everybody really, and so that will end the session for today, and we'll continue to have sessions like this, ISA Navi Mumbai chapter, and hope to educate ourselves as we should for the future. Thank you very much.
Thank you, Tarin. Thank you.
Thank you.
Thank you.
Thank you, everyone.
Thank you for coming.
It was awesome. It was super and very smooth. Good night.
Good night, everybody.
Thank you all.
Thank you,
Yeah.
everyone.
Good night.
Bye. Good night.
Good night, everyone. Yeah.
Oh, yeah. So leave the meeting here. How to leave the meeting here? How to leave the meeting? End here. End. Hey Baba, come here. Pedro. No. Leave the meeting.
Leave meeting.
That I press here. What is that? Sign and leave it.
Assign on because you have hosted the meeting, so give someone else. I select anyone only.
I have not hosted.
I just select someone, anyone. Assign whom you want to put as host. Just,